Heart sound S2 is characterized by aortic and pulmonary valve closure. So aortic valve closes first, followed by pulmonary valve, and the time lag between these two is 30 milliseconds. So this is normal and therefore is known as physiological split. Anything more or less than this is abnormal and is known as wide or narrow split. So to hear S2, we will place a stethoscope on the left parasternal line in the third intercostal space, and we have an Erb's point here, and S2 is heard best at this point. Now let us talk some conditions of narrow and wide split. So the first condition is patent ductus arteriosus. Here in this diagram you can see that between aorta and pulmonary artery there is patent ductus arteriosus, and the blood of aorta is going into the pulmonary artery. So what happens in this is that the blood of left ventricle, which was supposed to go into the body, is also going into the lungs through this patent ductus arteriosus. Now there will be more blood into the lungs because not only the blood is coming from the right ventricle but also coming from the left ventricle through this PDA. The more blood from the lungs will go into the left atrium, and eventually more blood will come into the left ventricle. So there will be delayed closure of aortic valve due to this, because more blood has to go out of the left ventricle. So aortic valve will close little late, so which will result in narrow split. So let's keep the first condition under narrow split, patent ductus arteriosus. Now let's look at the second condition, that is aortic stenosis. You can see in this diagram the aortic valves are stenosed in this, and because the valves are stiff due to calcification or rheumatic heart disease, it will take time to close. So A2 will close late, resulting in narrow split. So the second condition also is to be kept in this narrow split. So now let's look at the third condition, that is mitral regurgitation. We know that the valves are faulty here, mitral valves are faulty, and when the ventricles will contract, the blood will gush out into the aorta, but some blood will regurgitate back into the atrium. And due to this, they suppose earlier in normal human being 80 ml of blood was passing to the aorta, but due to the blood which has regurgitated, instead of 80, suppose 70 ml of blood is only passing to the body. And so aortic valve will close earlier because now less blood is passing. So there will be wide split. Next condition is ventricular septal defect. The same happens because blood of the left ventricle will go into the right ventricle, and there will be less blood in the left ventricle, and less blood has to go out from the ventricle into the aorta, and aortic valve will close earlier. So here also there will be wide split. Now the next condition we have is the atrial septal defect. In this diagram you can see there is a defect here, and the blood is going from left to the right, and normally what happens is during inspiration the intrathoracic pressure decreases, and due to which the venous return to the right side increases, and eventually there is more blood to the right ventricle during inspiration than during expiration. So this phenomena occurs in a healthy individual, that is in you and me. More blood will come into the right ventricle during inspiration than in expiration. Now suppose if we tell a patient of AST to inspire, so when the patient will inspire there will be more venous return, because as I already told that intrathoracic pressure will decrease, so more venous return will come to the right ventricle. So more venous return to the right ventricle, but due to this the left side blood will not be able to go to the right side because the pressure now is higher on the right side. So less blood from left atrium. But when we ask this patient to exhale, there will be less blood, less venous return, because we know in expiration the venous return is less compared to the inspiration. So less venous return, but now the pressure here is less. So now the shunt will be functional, and it will also have the blood of left atrium. So blood will be more in the right ventricle. So you can see that in both this condition, that is inspiration and expiration, the volume of the blood in right ventricle is constant, because when this increases, this decreases, this decreases, this increases. So the volume of right ventricle during inspiration or expiration is constant. So the pulmonary valve will close on the same time. That is, it will not vary, it will not be changing during inspiration or expiration. It will remain constant. So P2 will not be affected by inspiration or expiration, while the A2 will be. So here also P2 is fixed and A2 will close earlier. So there will be wide split. But in addition to wide split, there will be fixed split, which I explained here, because the volume of right ventricle remains constant and pulmonic valve is independent of inspiration and expiration. Moving on to next condition, that is right and left bundle branch block. In the right bundle branch block, what happens is the right side of the heart is blocked. So the current will be delayed in the right side of the valves. So right side of the valves will close late. So right side of the valves are, these will close late and these will close on time. So there will be a wide split. And left bundle branch block, what happens is the current will be delayed to the left side. So the left side valves, that is mitral and aortic valve, this will close late. So this will close late. So there will be a narrow split. So remember that in right bundle branch block we have wide split, while in left we have narrow split. So now the next condition we have is Wolff-Parkinson-White syndrome. In this, there is a bundle of Kent. The bundle of Kent joins SA node to the left side of the heart. This bundle of Kent has no discremental property. Hence, it conducts very fast, unlike this AV node, which is slow conducting. So impulse will reach left side through this pathway and will be delayed to the right side, because current is not using Purkinje network, but it is using intramyocyte conduction. So delayed information is provided to the right ventricle, hence it behaves like right bundle branch block. And yes, you are right, like the right bundle branch block, we will have a wide split S2 here also. Now talking about WPW syndrome B, type B, we have bundle of Kent on the right side. So right ventricle is stimulated first and delayed information will be provided to the left side, hence it will behave like left bundle branch block. So there will be, just like this, there will be narrow split. So let's complete our list here. As I've told you, fixed split is seen in atrial septal defect, and also we can write that Holt-Oram syndrome. In this syndrome, what happens is the patient has AST plus absent radial bone. And another condition is Lytton-Becker syndrome. In this condition, patient has AST plus mitral stenosis and TAPVC and Down syndrome. So the variable split variable split is seen in VST, MR, and yes, WPW type A, and here we have WPW type B, and also in conditions like left ventricular failure we will see a narrow split. So that's it. Thank you.